move a little bit into, what's new, what's out there, and basically as a dermatologist, what's getting me excited about being able to treat eczema. So like Kate, I'm a dermatologist as well, and I work at the Queensland Children's Hospital and also in private practice at Ascot Dermatology. So a lot of this Kate has already touched on, and it's a little bit of a busy slide, but I think it does incorporate quite nicely as clinicians, everything we think about when we see a patient with eczema. So basically we've got different treatment ladders depending on how severe a person's eczema is. Obviously, if someone's got very mild eczema, we're going to treat them quite differently to someone with moderately or severe eczema. So with mild eczema, as Kate touched on, we're looking to reduce the inflammation of the skin. And that can involve using topical corticosteroids. It can involve using things that are steroid-free, such as topical calcineurin inhibitors, or crisaborole, which is another steroid-free topical agent. None of this replaces the basic management though. So as Kate very nicely outlined, basic skincare is an ongoing, indefinite thing for every person with eczema. So using liberal moisturizer and sticking to things that are soap-free when washing, and being able to identify and avoid any triggers. When the eczema becomes more severe, then, depending on what the skin is like, we may add in things like bleach bath or Condy's crystals baths to try and prevent any secondary infection. If people are having very frequent recurrences in their eczema flares, we may add in a maintenance treatment. So say, for instance, when the skin is not too bad, people may be treating hot spots of their eczema routinely with some medicated creams. And if the eczema is very severe, we may introduce things like wet wraps. We may consider things like phototherapy, and then we may consider things like oral treatments, including some of the more traditional agents, such as methotrexate, cyclosporin, mycophenolate, or azathioprine. Or we may consider some of the newer agents like Dupixent or upadacitinib, which I'll talk about in a moment. And of course, if people's eczema is really severe, we need to consider whether this patient actually needs to be admitted to hospital. So when it comes to managing eczema, basically there's a lot of different things that clinicians think about and have to consider. The other thing that also comes into play is if people have very severe eczema and we're throwing everything at it, we need to think about, if it's not working, why is that treatment not working? So for instance, are there infections that are not being addressed? Do we have the right diagnosis? Are there other things going on, such as contact allergies, that may be contributing to the eczema as well? I'm just going to touch a little bit on dupilumab or Dupixent. So this may be something that, eczema sufferers or their carers have heard about. Hopefully some people listening into the webinar, this is something you might have heard about. But for me as a clinician, this has been a real game changer for how to manage eczema. So dupilumab is our first injectable or biologic treatment for eczema. And the reason this has been so effective is because it's really trying to target the specific parts of the immune system that are overactive in eczema. So as opposed to the traditional agents, which really just try to suppress the immune system, suppress inflammation in general, this is a really specific treatment. So without getting too much into the science of it, there are specific molecules that become active and are drivers of inflammation in the skin. And dupilumab is blocking two specific types of these, IL-4 and IL-13, or interleukin-4 and interleukin-13, which we know are really key drivers of the type of inflammation that we see in eczema. So why this is so important is that it's really just blocking that specific part of the immune system, and it leaves the rest of the immune system alone. So it's not technically suppressing the full immune system like some of the other agents, older agents that we would previously use for eczema. So it's considered to be much safer, but the added bonus is it's much more effective. Aside from just improving the inflammation of eczema, there's been a lot of studies now which show that it also improves the skin barrier dysfunction. So it doesn't replace moisturizer, But what the studies have shown is that even just with Dupixent alone, the stratum corneum, or the outside part of the skin, seems to become more hydrated, which is really quite amazing. We know that if people have eczema at a younger age, they may respond better to dupilumab, and there's another marker of white cells which sometimes also can predict response. This is a case study which was very exciting for me because this was actually my first patient that I treated with Dupixent, and it was before Dupixent was really readily available in Australia. It took a lot of hard work to get the medication for this patient, but basically this was a young boy who, since infancy had basically head to toe, all over body eczema, and was literally never getting to spend any time at home because he would wind up in hospital with severe sepsis, needing quite intensive treatment of his eczema. The photos at the top actually demonstrate his skin on a good day, but they were just the particular ones that his parents were happy for us to use for publication. But you can see, even looking at those photos, him on a good day is still quite severe, and he managed to clear remarkably with Dupixent and is still on it today. For me, it was such a huge moment because it really demonstrated the difference that this medication can have in people's lives. Now that I'm prescribing it a little bit more regularly, literally I see many patients every day who describe it as life-changing, which as a clinician, that's incredibly rewarding to hear. So upadacitinib, or Rinvoq, is the other medication which is new to the eczema landscape. So this is an oral medication. It's what we call a JAK inhibitor. So again, without getting too much into the science of it, the JAK inhibitors can block the same inflammatory molecules as Dupixent, but they're also blocking other molecules as well, and they're doing it from the inside of the cell as opposed to the outside of the cell. One thing that's quite exciting about this particular medication is that it has been shown actually to be even more effective than dupilumab in some of the studies. So this is quite promising, and I definitely use this in clinical practice quite regularly as well. So there's two very exciting new medications that are now available for severe eczema. I'm going to dip a little bit into some of the newer studies which have recently been published, which are looking at some of the controversies and things going on in the atopic dermatitis world. So one big question we get asked is, can treating eczema with something that's oral or injectable, can this halt the march of atopic disease? And there is some evidence that suggests it can. So when they looked at a lot of patients who'd been on Dupixent as an injectable medication, they found that actually these patients were 37% less likely to get new allergies, which if you have severe eczema, you often also do have lots of allergies to things. So that was quite exciting. And there are some clinical predictors of response to that, which I've outlined on the slide there. The other thing that was really quite interesting in the latest research is at a cellular level, looking at what's going on the skin. Even before people start to get the rash of atopic dermatitis, their skin structure and makeup appears to be abnormal. So as Kate sort of touched on earlier, there are these genetic factors that are a bit beyond our control that probably determine how the skin structure develops. And when they've done these studies, they've shown that those abnormalities seem to be present pretty much from birth. And when those abnormalities are present, and there's a family history of atopic dermatitis, people have a 54 times increased risk of developing atopic dermatitis. So, as Kate said, often people will ask, what am I doing that's causing the eczema? Well, often there isn't anything that you're doing. It's just this is the way the skin has developed. The use of moisturiser since birth has become a really big topic. So I think it was about 5 or so years ago, there were some studies which showed when babies were moisturised from birth, it reduced their risk of developing atopic dermatitis later on. There were a couple of studies in 2020 which showed the opposite. So it showed that when babies were moisturised, it didn't seem to affect whether they developed atopic dermatitis later on. But then one very interesting study last year came out that showed actually if we, aside from just using a plain moisturiser, use one that's got ceramides in it, which that's a really big keyword coming out with a lot of treatments at the moment. So the moisturisers with ceramide did seem to show a reduction in the development of atopic dermatitis later on. And that probably is because they are a little bit better at supporting that skin barrier function, but more research is definitely needed with that. Impact on caregivers, as everyone has alluded to today, this is obviously huge in people with eczema. There's been a big study just recently in the British Journal of Dermatology which showed that over 50% of people who are caring for someone with eczema spend more than 10 hours per week, which is obviously a very long time. And this can have a high or significant impact on a carer's life. And the domains that seem to have the highest impact were sleep, family dynamics, and family responsibilities. So as Vanessa touched on, I think it is very important that, carers look after themselves because these are all obviously significant things in people's lives. Another little systemic therapy update. So traditional steroid-sparing medications are definitely still used, and the most common ones are cyclosporin and methotrexate. These medications will still have a place in the management of eczema, but I think as the newer treatments like dupilumab and ipatacitinib or Rinvoq come through, they will play less and less of a role. Oral steroids are not recommended for atopic dermatitis. The reason for this is they can result in a severe rebound flare in the eczema. So they are, a Band-Aid solution at best, and I literally never prescribe them. The only time that they may be considered would be if we were thinking about transitioning a patient to other medications that are not steroids. Other than that, I don't think they have a place in the management of eczema. Dupilumab or Dupixent has been approved now in the US for children from the age of 6 months. So that's very exciting. In Australia, it's only currently available on the PBS for children who are 12 years and above. However, it can be accessed for children who are younger than 12 years. At my hospital, for instance, it's funded by the hospital. So what's new? What's emerging? It's a very exciting time for eczema treatment. There are lots of trials going on and lots of research going on into new treatment options. So I've just listed a few things here. I won't go into it in any detail, but there are a few steroid-free creams which are being developed, which is very exciting. There are other biologic agents which are currently in the works also, aside from dupilumab for eczema. And apart from ipatacitinib or Rinvoq, in the US, they're also using another JAK inhibitor called abrocitinib quite routinely for children over the age of 12. These are some of the biologic agents which are working their way through the research trials at the moment. Again, I won't go into it in too much detail other than to say that they exist, and it's exciting that hopefully we will have a few more options available for our severe eczema patients.